Oh, you're good, Yuki. Good morning, everybody. It is great. It is great to see you all today. Thanks so much for joining for another Wednesday VMR session. For those of you who I haven't had a chance to meet before, I'm Jack. I use he, him pronouns. I'm one of the CP Solvers team members, and it is always a treat to get to be here with you all. I am having mixed emotions this morning. I'm sad because my usual co-pilot, Charmise, is not able to join us this morning. She's on service right now in her team's post call. And in the flesh, clinical problem solving is calling her right now. But that sadness is tempered and softened by excitement, because that means that I get to co-discuss this morning with the one and only Mark Heslin. Mark, I'll turn it over to you to say hello. He is no stranger to anyone in the VMR community, and very excited that he's going to be discussing today.
Hello, everyone. I'm Mark, one of the third-year medicine residents at UPenn and one of the Academy members. So nice to be here after a long 2-month stretch on the ICU. It's so nice to kind of be off and be back with you all. And I will also pass it to Yuki.
Thank you for having me today. My name is Yuki. I'm a graduate from Japanese medical school, and I'm currently working in the countryside of Japan as a general internal medicine physician. And actually, I know Mark. We met, right? 2 weeks ago?
Yes, we met at SIDM. It was so nice to meet you in person. Yeah, it was so fun. It was an unbelievable conference.
Yeah, I get surprised because actually I attended SADM in Cleveland 2 weeks ago, and I met Mark and Yusef and Joaquin strongly encouraged me to present here, and that's why I'm here today.
Well, as I finish chewing my apple, I would just say that is so exciting to hear that these different connections within and outside of VMR are continuing to grow.
In that conference, I'm actually I'm going to apply to internal medicine in the next cycle. So on Twitter, I was just browsing many posts, and I happened to find this team, and I happened to find a SIDM conference. So I was super lucky.
That is awesome. That is awesome. Well, we are so thrilled to have you here this morning, and really excited for the case that you have for us. I will turn it over to David, who I think is scribing, to pull up the whiteboard, and we can go ahead and get started. Yuki, take us away with the first aliquot here. Oh, Yuki, I think you're muted.
Sorry. Okay, again, the case today, a 67-year-old man with past medical history of advanced stage pancreatic tail cancer. It was T4N1M1, presenting with confusion followed by an unresponsive state.
All right. Do you want us to stop there?
Mm-hmm.
All right. Mark, we got cancer and confusion and unresponsiveness. What are you thinking?
Yeah, and Yuki, one question I had for you is, how long has the confusion been going on for?
This confusion was his first experience, and that was started on the morning of the day of transfer.
Perfect. Yeah, we all here obviously love diagnosis, but when I hear someone is unresponsive, I'm kind of shifting towards more treatment before diagnosis in this case. So, the CP solvers have the phenomenal missed mnemonic, but before that, I'm going to, always check our ABCs, right? I definitely going to right away want our patient's vital signs. I'm going to want their oxygen saturation, probably a venous blood gas too, to see if the patient is, very hypercapnic and require intubation. and also would like a sugar as well, because some of these things, might, if we treat those things, that could, resolve the confusion. So I just want to focus on that first. This patient sounds very sick and, unresponsive. So I definitely am going to want those vital signs in some of those initial labs. But if we kind of open up our, our beautiful MIS mnemonic, thinking of metabolic, infectious, structural, toxins, and meds as our, our approach to alter mental status, I'll kind of just adding on the time course, this being like a hyper acute confusion, right? That kind of makes me think of more either toxic metabolic or more toxic or drug causes of confusion, right? You can think of someone maybe with an opioid overdose or some sort of drug overdose, or a new medication that they started that cause confusion, hypoglycemia, and then things like vascular insults, right? Like a stroke or a subdural hemorrhage. A stroke usually, an ischemic stroke is usually not going to just cause confusion unless it's leading to cerebral edema and possibly brain herniation. You're usually going to have other focal neurological deficits, but a subdural hematoma definitely could. And then kind of just layer in the patient's past medical history. When I think of someone that has cancer, I kind of think of a few different things. I think, could this structurally be related to their cancer, right? This patient has a cancer in their belly, right? Pancreatic cancer, which unfortunately sometimes can go to the brain. So I'm also, think of metastasis, right? With maybe associated cerebral edema and brain swelling. I'm thinking, could this be related to treatment of the cancer, right? I'm not sure. We'll probably learn about this patient's treatment history, right? Are they being treated with, some sort of chemotherapy that could cause, confusion, right? Like something I think is like cytarabine can cause like cerebral ataxia. And there's just a long list of others that, and then also paraneoplastic, paraneoplastic encephalitis or other paraneoplastic syndromes that can affect the brain. So it's kind of the first kind of initial things I'm thinking about. I'm not going to go dive too deep into MIS right now before we get more of the HPI, but I definitely want to stabilize this patient first, get some vital signs, get some basic labs, and see if I have to treat before I diagnose here.
I have nothing to add. Yuki, take us forward here.
Thank you so much, Mark. Actually, you concluded everything. Okay, history of present illness. Prior to the day of transfer, he had been in unusual state of health and done household chores like cooking. On the day of transfer, in the morning, his wife found him confused and urinating in his bed, vomiting the transfer to the ear. During the transfer, he was becoming increasingly unresponsive. Then the review systems was difficult to take directly from the patient, but positive for a few week history of nausea, vomiting, weakness, loss of appetite, and weight loss, according to his wife. And his wife attributed these symptoms to side effects of chemotherapy. And his wife denied his recent history of head trauma. And his past medical history was notable for pancreatic tail cancer, just finished 3 courses of gemcitabine plus nab-paclitaxel via CV port, and atrial fibrillation, status post radiofrequency catheter ablation. In terms of medication, he was on oxycontin, celecoxib, nalbendin, magnesium oxide, vonoprazan, and prochlorperazine. He did not have any food and drug allergies. He retired and lived with his wife, and he denied recent drinking, smoking, and recreational drug use.
All right. Well, a rich trajectory here as we kind of see more of this case unfolding. And I think, as Mark was alluding to in the first aliquot, understanding the tempo is incredibly helpful as we try to gain clarity on altered mental status, but also understanding what the encephalopathy syndrome is characterized by. And I think what we see here is that this acute episode of unresponsiveness was preceded by some normal behaviors earlier that morning. Think about the missed mnemonic. Some of the different diagnoses that fall under that have very characteristic or stereotyped prodromes before the unresponsiveness develops. For example, someone who has a seizure, right? We wouldn't expect them necessarily to be confused, moving around the house and urinating, but we might expect more seizure-like movements. And so I think if we say, okay, well, how does this past medical history help us better understand this? What it seems to be is that there is a sort of subacute syndrome of maybe a combination of inflammation and possible just general deconditioning, the weight loss, the weakness, the nausea, the vomiting, but that is now crescendoing into acute altered mental status and then leading into unresponsiveness. I have nothing to add to Mark's dissection of the two big things we're going to prioritize in the setting of unresponsiveness, which is the hypoglycemia and the hypercarbia. But if we think about other potential things within the mismnemonic that could brew for maybe a few weeks or for a few days, then I think the two things that start to really come up are going to be the metabolic complications as well as the infectious complications that we can see leading to altered mental status. For example, hyponatremia can slowly progress and move through various phases of symptomatology. Somebody may be slightly confused when their sodium is in the 120s and become floridly obtunded if their sodium moves down into the 1-teens or lower. Similarly, calcium abnormalities, while we wouldn't necessarily expect somebody to become this obtunded for them, can progress over the course of days. And as a result of that progression, so too can the degree of the individual's encephalopathy progress. The infectious syndromes, like how we prioritize those, are really going to depend on where things are localizing. And as of this point, we don't have really many localizing symptoms outside of the central nervous system, right? We don't have things like fevers or chills, and there's no organ-based manifestations that we see from the history, although acknowledging, as Yuki said, that is going to be incredibly limited. And so the only thing that I will add here is if we look at then asking the question of, okay, how does the further information that we got about the past medical history help us weigh those things? We can think about the framework for the neurologic complications of cancer that Mark laid out so well, right? And we can sort of take that framework and really organize it into really four primary mechanisms by which cancer can affect the neurologic axis. We can see direct tissue damage from the cancer itself or from the chemotherapy, as Mark mentioned, metastatic disease. We can see vascular complications that develop from the cancer or from the chemotherapy. For example, as we were alluding to, right, cancer is an incredibly hypercoagulable state. And so individuals are going to be at increased risk of strokes. The other thing is that some chemotherapeutic agents can carry vascular complications that come with them as well. And if we look at this gentleman's chemotherapy regimen, I don't know much about the vascular complications of paclitaxel, but I do know that there's some association between gemcitabine and vascular complications like a thrombotic microangiopathy or a microangiopathic hemolytic anemia. So learning this about the chemo could potentially expand our vascular hypothesis here. So those are the first two mechanisms, direct tissue damage and vascular problems, either from the cancer or from the chemotherapy. And then the other two categories are going to be nutritional changes and immunologic phenomena. The immune system could be down, leading to infections, as Mark said, or the immune system could be dysregulated, leading to things like paraneoplastic phenomena. And I think that sort of those four, or that almost 4x2 square of the MIST mnemonic and the four neurologic complications of cancer is really what is going to be driving the case right now. I don't feel like I can make a ton of progress beyond sort of listing out those mechanisms and exploring some of those threads that we have. But I'm curious, Mark, if there's anything else that's jumping out to you from what we got so far now about the background history.
No, the only thing I'll add is just with the preceding kind of like GI symptoms as well. And unfortunately, some of our patients with cancer do get very malnourished. I'm also kind of just thinking about kind of nutritional deficiencies that could, lead to altered mental status. In the hospital, I have really the lowest threshold to start IV thiamine in patients because it's a very kind of low risk intervention. And, Wernicke's encephalopathy is, rather common. You can think of, vitamin B1 deficiency, vitamin B3 deficiency, vitamin B12 deficiency. And I'm not sure, I guess the patient didn't get removal of part of their pancreas, but if they did, you can start thinking about malabsorption leading to an increased risk of some of these vitamin deficiencies. So I'm definitely going to want some of those as well. But yeah, definitely want to hear more.
Okay, I'll move on to the next calculate. His vitals, temperature was 37.3 Celsius, 99.1 Fahrenheit. Blood pressure 162/85. Heart rate was 85 beats per minute regular. Respiration rate was 12. And oxygen saturation was 98% on room air. On physical examination, the patient was unresponsive. DCS was E1, V1, and 4. HMT exam showed a traumatic head. Pupils were equal and round, react to light, but showing like roving eye movement. Supple neck and clear oropharynx without X-rays. Chest exam showed regular vacuum rhythm, no murmurs. Pulmonary exam showed clear to auscultation bilaterally. Abdominal exam showed a soft and flat abdomen with positive bowel sound in all 4 quadrants, and no tenderness for deep palpation. Neuro exam showed no Babansky and Brudansky signs bilaterally. Deep tender reflexes were reduced but symmetric. Scan extremities exam showed no rashes, edema, no redness, or no exudate along right subclavicular CV port, no also node, no genuine lesions, and no splinter hemorrhage.
All right. So we got some, I think, some progress that we can make, both in terms of what is involved in the exam and also maybe what other organ systems don't seem to be involved yet. Yeah, Mark, I'm curious, what do you make of the exam that we have so far?
Yeah, I feel a lot better now about our vital signs. I was very worried when in the first aliquot, when I heard the patient was unresponsive, maybe thought we were going to have, hypoxemia or some sort of, vital sign abnormalities. I'll just kind of pick apart the blood pressure right now. So I'll say, the patient has a pretty wide pulse pressure, which can mean a lot of things. I would say most commonly in someone that's 67, they could just have, a history of isolated systolic hypertension as our arteries get pretty stiff as we age. So that, that could be a cause. The patient could be in pain, increasing, their blood pressure. Another thing is to think about is a high kind of cardiac output state that is increasing the systolic blood pressure out of proportion to the diastolic blood pressure. So you can think of things of like, I guess I think kind of something that I mentioned before, like thiamine deficiency, wet beriberi could lead to like a high cardiac output state, right? And then you can think of states of low SVR that are proportionally decreasing the diastolic blood pressure. So you can think of any distributive state like sepsis. It's important to remember, just because you have a normal blood pressure, that does not rule out shock or any sort of distributive process. But I am reassured we're not febrile, we're not tachycardic, we're, our blood pressure, our vital signs are a little hypertensive. I'm glad that we have, it seems like there's no abnormalities on the neuro exam. Did I hear that correctly? Any like focal neurological deficits, Yuki?
Actually, this patient was unresponsive, so difficult to take neuro exams. So that's why I presented a little bit.
Yeah, I'm glad at least we have things like, no Babinski's or Brodzinski's sign. We don't have any obvious signs of upper motor neuron disease, right? I definitely encourage you all. I know sometimes, when we admit patients to the hospital, they have altered mental status. Maybe chalk up to a toxic metabolic phenomenon. And then sometimes we skip over doing a good neuro exam. But I really encourage you guys that any patient that comes in with an altered mental status to the hospital, do a good neuro exam. I will, wake patients up in the middle of the night. I tell them I'm very, very sorry, but I just need to do a good neuro exam, because if there's some sort of, vascular or brain insult, like time is brain, right? Those neurons, if it's a stroke or something else, die at a rapid rate. So I will, like I said, wake patients up in the middle of the night to a neuro exam. But I would say, it's tough sometimes with a patient that's altered, but we're not at least, deep tendon reflexes were reduced. Okay, sorry, I'm just seeing that now. So I guess we're getting some hints at maybe a lower motor neuron phenomenon. That's usually what hyperreflexia means, whether that's evidence of a peripheral neuropathy. We'll get some sort of suggestions maybe from the labs of common causes of peripheral neuropathy. Some chemotherapy agents can do it, common things like diabetes, thyroid disease, et cetera. We can kind of get into that more if that's the route we're going down. But then also keeping in mind that things like spinal shock, like acute spinal cord damage, can first present as reduced reflexes in its acute state and then kind of progress to more of a hyperreflexia. So overall, I'm reassured by the vital signs, but still definitely worried that this patient is, unresponsive and has some decreased deep tendon reflexes. But Jack, I'm curious, what do you think?
No, I think you really honed in on what is jumping out to me the most right now about the exam at this point in time. I think I am really struck by the degree of profound encephalopathy that we see here, right? That GCS of E1, V1, M4 at a GCS of 6 is a very, very reduced GCS here, which I think from the management perspective, as you were alluding to up front, Mark, right, thinking about the possibility of needing to intubate this gentleman just for sheer airway protection if his mental status is so reduced. And then also thinking about just the extent of cerebral dysfunction that has to be present for somebody to have a GCS that is that low. So we're seeing probably diffuse cerebral involvement here. And then also the reduced deep tendon reflexes that you mentioned. I think that's a really astute and important pickup here. As you mentioned, right, usually when we see reduced deep tendon reflexes, we localize this to a peripheral nervous system process, right? The peripheral nerves are going to be involved and we're going to get dropped reflexes. But we have such extreme cerebral dysfunction here as well, right? Most peripheral neuropathies, like for example, we think about autoimmune demyelinating polyneuropathy, they're not syndromes that are characterized by altered mental status. So we have to ask ourselves the question of how do we have such profound CNS involvement with this degree of encephalopathy, as well as maybe some clues to the peripheral nervous system. One hypothesis is, as you, I think, brilliantly pointed out, is that the cord could be acutely impacted, and in hyperacute myelopathy or myelitis, right, we can see reflexes that are initially dropped and then become hyperreflexive. So the upper motor neuron findings of hyperreflexia, as you said, take maybe hours to days to develop, while in the first minutes to hours in that acute phase, we see dropped reflexes. So one hypothesis is that what we're dealing with is an encephalomyelitis that's in the very, very early stages of impacting the spinal cord. The other hypothesis is that this may be a process that isn't affecting the whole cord, but is very strategically impacting both the brain and a part of the spinal cord that can cause things like flaccid paralysis. And that's going to be something like a disease that affects the anterior horn. Classically, that's something like poliovirus, which we see very, very rarely now, or I should say do not see in the acute phase anymore because it has been eradicated. But certainly other viral encephalitises, like West Nile virus, for example, adenovirus, they can also directly impact the anterior horn and lead to flaccid paralysis. And if there's also an encephalitis associated with it, we could see this degree of cerebral dysfunction. So I think those hypotheses that you elaborate, what we're dealing with is an encephalomyelitis, and the myelitis part of it happens to be either very early, leading to reduced reflexes, or very strategic in the area that it's impacting in the anterior horn cells is one possibility. And then the other possibility is that this is a disease process that affects both the peripheral nervous system and the central nervous system simultaneously, leading to peripheral neuropathy, as you mentioned, and very profound cerebral dysfunction. And there isn't a long list of things that does that. And the things that tend to occupy the top of that list of things, again, both the peripheral and central nervous system simultaneously tend to be immune-mediated or paraneoplastic-mediated disease processes. And so I think our task from here is to say, okay, to what extent is the peripheral nervous system involved, if at all? Because that will be a key branch point for us to understanding, is it the brain and the cord, or the central and the peripheral nervous system? Brain plus cord could be infections and immune-mediated disease processes. So too could CNS plus PNS. But the central plus peripheral hypothesis, I think, really prioritizes immune-mediated or paraneoplastic phenomena.
Thank you for amazing discussions. Yeah, awesome. And yeah, I got really surprised because, yeah, as I expected, yeah, CP Solvers shared me a lot of information. So thank you for clinical teaching pearls. Okay, and let's continue looking at his laboratory data. His CBC showed white blood cell count 5370, hemoglobin 9.5, platelet count 102,000. His BNP showed sodium 147, potassium 3.6, chloride 106, BUN 9, creatinine 0.47, plasma glucose 116. His LFT showed AST 50, ALT 30, total bilirubin 1.0, LDH 597, ALP 331, CK 53, albumin 3.1, calcium 9.0, corrected calcium 9.9. CLP was 3.4, which was slightly elevated, and ammonia was within normal limit. PTINO was 1.3, and APTT 34.9.
Yuki, just for the sake of time, do you mind giving us some of the other data, like the head imaging or any other studies that you had?
Sorry, it is all of my information in terms
Oh,
of blood.
wonderful. So we're making the diagnosis from the labs here.
Do I need to proceed to echocardiogram and health CT? Is that okay now?
Yeah, that would be wonderful.
Okay. And cardiac ultrasound revealed no ASD, VSD, PFO, and no atrial enlargement and normal ejection fraction. And non-contrast head CT showed no hemorrhage and no space-occupying lesion. And we added contrast-enhanced body CT, which showed no multiple liver metastases, no ascites on the liver surface, new multiple granular shadows on the posterior aspect of the left lung, but no signs of pulmonary artery defect.
Great. And Yuki, just so that we can manage our time well, how much more data is left after this?
And I have another imaging.
Another imaging?
Yes.
Why don't you go ahead and give us now, just since this is usually a 30-minute case, just so that way we can try to stick to as close to the 30 minutes as possible.
Sorry, so would it be okay to proceed to the last imaging now?
Yeah, that sounds perfect.
Okay, and here's head MRI showed a flare high signal intensity And decreased ADC maps with diffusion-weighted imaging, showing high signal from the left answer to the palliative lobe, and several small infarcts involving the bilateral anterior and posterior circulations. No brain hemorrhage. And on MRI, the left MCA was almost occluded at the inferior branch.
All right. All right, Mark. What are you thinking here now?
Yeah, so I guess maybe I'll just attack the labs real quick. I love dissecting labs here, and I think it's important when you're interpreting labs is just to always know people's baselines, right? So if this patient has a baseline hemoglobin of 13 and then now it's 9.5, that's worrisome. Most of our patients that are really sick in the hospital, especially patients with cancer undergoing chemotherapy, usually have a lower baseline hemoglobin from anemia of chronic disease, medications, etc. And then the platelet count, the thrombocytopenia of 102. I just want to go through my no misdiagnosis of thrombocytopenia and anemia, right? Thinking of thrombotic microangiopathies and DIC and HIT, right? Our renal function is rather, normal, depending on what the patient's baseline is. So probably makes, a TMA less likely, which, a TMA can also cause altered mental status and some CNS insults. DIC is definitely something I get concerned about. It's someone that's very hypercoagulable with pancreatic cancer, but here our INR is slightly elevated. Our PTT, I think I heard, was normal. Our LDH is elevated. However, our patient does have cancer. So I think, that they probably have a baseline high LDH. And then our T-Billy is kind of top normal. So, and I don't think our AST to ALT ratio is also kind of 2-to-1. Maybe there'll be some, evidence of hemolysis. I would definitely be very interested in a haptoglobin as well. But probably my suspicion for DIC is pretty low at this point, but, getting a haptoglobin and fibrinogen definitely would be useful. But in terms of our altered mental status, I know we have imaging findings, but our sodium being 141, that's a cause of altered mental status. That is normal. Our renal function is relatively normal. Our calcium, our corrected calcium is relatively normal. Our glucose is normal. So a lot of our BMP evidence of that could be triggers of altered mental status is pretty normal. Our LFTs, our patient doesn't have a history of cirrhosis, but they do, they do have liver metastasis, but probably likely not liver synthetic dysfunction leading to hepatic encephalopathy. So in terms of our labs, I definitely would be interested in hemolysis labs. Just to make sure that thrombocytopenia and anemia isn't evidence of some sort of hemolytic process that maybe could be related to the CNS findings. And then we have an elevated CRP. CRP is very nonspecific. I guess the only thing I'll say about the CRP, sometimes getting an ESR with it, and there's some conditions that can lead to a discordance of ESR CRP. So it's sometimes interesting diagnostically. Sorry, someone is calling. But yeah, that's not too much progress in the labs. I think all of the money is going to be in the head imaging. So I'm curious, Jack, what do you think about that?
Yeah, Mark, I think your analysis of the lab is absolutely brilliant. And I just want to applaud you, right? In this sort of deep, dense wall of data that we're sifting through from the spectacular case that Yuki has prepared for us this morning. Yuki, I just want to say, I can see the thought and detail and work that you put into making this both a challenging and also educational case to solve. And I think the brilliance that Mark is bringing is a testament to how well that you have put this together. And Mark, how much time I know you have invested into thinking through cases like this. The head MRI, to me, I think I'm contending with three hypotheses here. With looking at the imaging that I think your analysis of the labs really helps with. What we have is we basically have, I think what sounded like scattered areas of high signal intensity throughout the brain, which as well as this finding of a near complete occlusion of the MCA. So if we think about the finding of scattered signal intensities throughout the brain in somebody who has cancer, those could represent metastases to the brain, or they could represent infarcts to the brain. If they are infarcts, that pattern of infarcts is very much an embolic pattern, And if they are metastases, we have a plausible explanation for those metastases, which is this underlying pancreatic cancer. I don't think of pancreatic tail cancer as having a particular predilection for the brain, but certainly it can metastasize to the brain. So looking at just the parenchymal findings, right, we're sort of contending with, is it METs or is it strokes? And that can actually be really difficult to determine just on upfront MR imaging. Subacute infarcts can look a lot like brain mets when you look at even diffusion-weighted imaging on MRI, but sometimes a short delayed repeat MRI to see how these lesions evolve can help get more clarity there. But the finding of the MCA near complete MCA occlusion, I think, really strengthens the vascular hypothesis here, right? If this sort of scattered areas of scattered areas of high intensity lesions in the brain are going to be METs, we have to then explain why it looks like there's an active stroke in the MCA here. And so I think the vascular hypothesis that the MCA occlusion helps to advance then really turns our attention to the possibility of underlying hemolysis, as you mentioned, right? If we see anemia, thrombocytopenia, elevated bilirubin, and a high LDH, that combination makes us think about hemolysis in the specific class of hemolysis, like an underlying microangiopathic hemolytic anemia or a TMA. And as we were talking about before, gemcitabine-induced TMA is incredibly rare and also incredibly devastating complication of gemcitabine therapy. And so I think that is a hypothesis that we do need to explore here, given the laboratory signature that you picked up, Mark. But I think my enthusiasm for that as the final diagnosis is tempered just by the base rate and how rare it is compared to the much more common neurologic complications of cancer, whether that be brain mets, strokes from the underlying hypercoagulable state, or very severe infiltration of the CNS with things like lymphangitic carcinomatosis. And so I think those would sort of be the possibilities that I would be holding here. Metastases to the brain, lymphangitic spread to the brain, and strokes, with one of the underlying explanations for strokes being the possible but very rare complication of this chemotherapy with an underlying TMA.
Thank you for sharing great ideas. So this will be my revealing slide. Based on the imaging studies and his current condition, so with aggressive cancer and on chemotherapy recently, several infection due to Churchill syndrome was suspected as the final diagnosis. We concluded that the cause of impaired consciousness was several infection. And after consultation with neurology, gastroenterology, and palliative care, and discussion with his family, he was finally admitted to palliative care unit and received heparin infusion.
Thank you for bringing this case. It sounds like a really sad outcome for this patient. Just grateful to you for bringing us this opportunity to learn and think through this case. And knowing how much time it takes to prepare a case like this, I just want to say thank you so much for doing it. And thank you to the case review committee team as well for creating this educational opportunity. And hopefully this can be a way for us to highlight and commemorate this individual who it sounds like had a really unfortunate outcome from a really severe and devastating disease. I think a really rich case to get to learn from here. Mark, I'm curious if you have any reflections before we turn it over to Mariana to bring us home with the teaching points.
Yeah, no, thank you so much, Yuki, for sharing. And I'm sorry about the outcome of the patient, but this is so well presented, and you can just tell how thoughtful you were with just putting together the case. And I truly, learned so much, and I can't wait to kind of take a deep dive into Trousseau syndrome and to this case. Thank you so much, and thanks, Jack, for co-discussing.
It was a blast, my friend. It was a blast. All right, Mariana, take us home with the teaching points.
Hello, can you hear me? Okay, so thank you, Yuki, for this amazing presentation. Thank you, Jack and Mark, for this amazing discussion. And let's go ahead with the teaching points. So we started with this patient with unresponsiveness, and when we have a patient presenting like this, we need to prioritize management over diagnosis. So we need to look for hypoxemia, ABG, vital signs. We have to think, is this patient protecting his airway? So maybe it's necessary to think in intubation. So the main thing here is stabilize patient before to think in diagnosis. And after stabilizing this patient, we can think in the AMS mnemonic, MIST, thinking in metabolic, infection, structural, and toxin causes. This patient has a history of cancer. And so this AMS can be associated with his cancer. And I learned today that we can think in four main causes for this AMS associated with cancer. That is directive tissue damage, vascular complications due to a hypercoagulable state or due to KT treatment, and also due to nutritional deficiencies such as B1 and B12, and immunological symptoms such as a paraneoplastic phenomenon. Metabolic and infections here are the most important factors in this case, but we didn't have signs of fever or chills, so we would think less in infections in this case. And after, with the physical exam, we saw this patient had a hypertension. So in this case, we can think in age, stiffness, pain, high cardiac output state, low SVR or sepsis. And also we learned the importance of the neuro exam here. We have to look for focal deficits, and mainly patient with high risk for stroke, we have to do a good neuro exam because time is brain. And also we talked about profound encephalopathy, reduced brain function, diffuse cerebral involvement. We thought about encephalomyelitis and also viral encephalomyelitis, and also immune and paraneoplastic mediated process phenomenon. And so Mark pointed out here about the thrombocytopenia that the patient presented, that we cannot think about differential diagnosis such as TMA, DIC, and other hemolytic process. After the MRI, we saw a near complete occlusion of the MCA, and then we started to think about metastases or infarcts, mainly in the embolic pattern, and also side effects of the KT. And the final diagnosis ended up being Trousseau syndrome, which was a paraneoplastic syndrome because of the pancreatic cancer. That's it. Thank you so much.
Thank you so much, Mariana. An absolutely incredible distillation and emphasis of the key learning points here. Thank you all so much for coming out this morning. It was great to see everybody as always. Yuki, thank you again for bringing such a fantastic case for us all to get to learn from, and again to remember this gentleman as somebody who I'm sure was many things, and today he got to be he was our teacher today. So Yuki, thank you for bringing that forward, and I hope everybody has a wonderful rest of the week, and we'll see you all soon.
Yeah, thank you so much.